Hello, my name is Dr. Edward Atty. I'm a physical medicine rehabilitation specialist and also am board certified in the subspecialty of pain medicine. I'm also currently a clinical professor and director of a spine and pain fellowship at Michigan State University. I think it's always good to know the credential of the person who you're listening to, so have some experience and expertise in the area that they're speaking of. So today we're going to talk about basically opioids in the pain management world and the pharmacology of opioids. Uh, Whenever we're talking about a medication, I think it's always just important to start what's the objective of the therapy you're starting or the therapy you're implementing. And this all depends on the patient selection, appropriate patient selection. So you want to make sure you're applying the therapy to the patient that requires that therapy or it's going to be appropriate for that patient. So what level or what dose are you going to initiate it at? Is it going to be a trial? Is this something you're going to continue giving the patient? We're also going to talk about some of the opioid guidelines. Then we'll get into the mechanism and action of these opioids and how they work and how different they can be from each other, even that they all are classified under opioid, and which opioid is appropriate for the patient. We're practicing in an age where we have multiple different opioids that we can use as our tools for treating the patient. Then we're going to talk a little bit about tolerance, dependence, how these are always misunderstood, and also talk a little bit about withdrawal, a little bit about abuse and addiction, and also we're going to talk a little bit about the side effects and how the individual opioids are different than each other. So when we look at medication, we want to have some kind of algorithm, which is typical of any medical treatment, especially in chronic pain. Again, we talked about how it's appropriate to select the right patient. And when the decision is made to start the patient on an opioid, what do we want to assess? And not only what do we want to assess, but are we going to start the patient on a trial and reassess the patient? And are we going to continue the medication or stop the medication? So we want to first consider, has all the alternative treatment been tried, such as conservative treatment? It could be nonsteroidals, could be other medication, could be physical therapy, possibly injections, possible modalities. And then if patient is failing a comprehensive pain management program, then maybe consideration for a trial. Again, the word trial I think is very important. And then reassessing the patient and see if we need to continue that trial or maybe talking about an exit strategy if the patient is not responding well. So when we talk about patient selection, it's important that we understand that opioids are an important class as therapeutic agents used to manage acute pain and chronic pain. Opioids should be reserved only after trials of non-opioid analgesic and other medication and treatments are tried, as we discussed earlier. It's also important to consider opioids for moderate to severe pain, not just for mild pain. And patient does not have any contraindication for use of opioid and also does have contraindication, maybe could not use NSAIDs or anticonvulsant or neuropathic agents. So I think it's important to go through the patient selection process before even considering an opioid treatment. So questions to consider before initiating a trial of opioid therapy. What pain syndrome is appropriate for opioid analgesic? Are we dealing with, mainly musculoskeletal pain, or are we dealing with neuropathic pain? What patients are appropriate for and candidate for opioid analgesia? Should opioids be the first analgesic class prescribed? And we talked a little bit about this before. What patients are at high risk for abuse and diversion of opioids, and therefore, assessing the patient and from multiple angles is very important prior to even prescribing an opioid. Therefore, the critical part of prescribing opioids is assessing the patient fully and doing your due diligence before even starting patient on an opioid. So, initiating opioid therapy for moderate to severe pain, unresponsive to non-opioid analgesia, try to start with the weakest opioid. Could be like a codeine, could be maybe a Tramadol or Ultram. And if these medication, and now we have also maybe something like Belbuca for more chronic pain, and the patient is not responding to the milder, the weaker opioid, then we can consider the stronger opioids such as, hydrocodone, oxycodone, morphine, fentanyl, or possibly methadone. We also got to look at the cost, how well they're going to tolerate it. Is it easy for the patient to take it and they're going to be compliant with it? Are we going to start a short acting at a low dose and then maybe eventually consider long acting and using the short acting for rescue doses for breakthrough pain? We also need to, it's very important we document an exit strategy and discuss it with the patient prior to even prescribing or initiating any opioid. Then we look at what are the options when we start thinking of continuing the opioid. Is the patient getting effective pain relief? And this is where the 4 A's become very important. The first A is analgesia. And then very important is the function improvement in activities of daily living, psychosocial functioning. Then we got to look at the adverse. The third A is adverse effects. So are they having any side effects? And the 4A, which is very concerning, are they developing any signs of addiction? Not tolerance, not physical dependence, but actual addiction. So the 4 A's are analgesia, activities of daily living, adverse events, and then look at addiction. So I think these are very important part of every assessment and reassessment, and allows you to decide, are we going to keep the patient on the same opioid, modify the opioid, or discontinue it? So it's really important to document and monitor the 4 A's. When do we consider modifying in a trial of opioid therapy? Again, looking at patients' improvement in analgesia, activities, daily living, making sure they're not having any side effect before we raise their dose of opioid? Or do we need to try a different opioid from a different class? And what is the guideline, or what factors into deciding on a different opioid? Is the other opioid better for their type of constant chronic pain, or is it better for their breakthrough pain? And in regard to how reliable a urine drug screen, again, urine drug screen play a very important part of continuing opioid therapy. They are very reliable when you look at the gas chromatography, the urine drug screen we send to the lab, and it gives us a breakdown not only of the levels of the drugs but their metabolites. But the urine drug screen that's done in the office, the screen is not as reliable, has a lot of false negative and false positive, so we have to be very careful not relying on that to manage patients, and especially to discharge patients from treatment based on a screening that's not reliable, such as a gas chromatography. So again, we talked a little bit about exit strategy. So it's important that we initiate an exit strategy when we're starting opioid therapy and agree with the patient what the criteria for failure in the trial. So common failure issues could be lack of improvement in the pain, analgesia, lack of improvement in activities and function, and this is the second A. Or the third A could be the adverse side effects. Are they having too many side effects? And the fourth one, are they showing any signs of addiction and abuse, possibly noncompliance? And we need to document weaning the patient or tapering the patient if the trial is not successful. So I think for patients who are on long-term opioid, recognizing which patients are not responding well to opioids and deciding how to wean them off the opioid is very essential part of treatment. So the American Academy of Pain Society and the American Academy of Pain Medicine have put out guidelines to manage chronic non-malignant pain. And we talked a little bit about it's very important that we conduct a comprehensive evaluation. That means a good history and their failure of other treatments. Also, a good exam documenting their diagnosis and having a good working diagnosis. And then comes assessing their risk by doing risk assessments, which are available and easy for the patient to fill out. And the risk assessment and risk stratification could be also making sure the patient is agreeable to the pain agreement, looking at his medication history and reports that's provided by the government, and also urine drug screens. Then we look at reassessing every time we see the patient, make sure they are compliant, they're showing signs of improvement in analgesia and activities. Also making sure the patient is educated and given an informed consent. Also looking at making sure the patient is not having any side effects, and if they are, anticipating some of these side effects, either treating them prior or managing the side effects. And also treatment has to be customized to the patient. Not everybody is going to respond to the same opioid or the same dose, and we'll discuss this later. And also implementing other adjunctive treatment, other medications, modalities, rehab therapies, injections. So using all your different tools to be a comprehensive pain specialist to manage the patient different pains and allow him to function at his fullest, and also evaluate the patient for repeated dose escalation and possibly weaning off the medication or considering as needed therapy for breakthrough pain. So if a patient is on a long-acting and still having breakthrough pain, maybe this is where a short-acting to be used as needed can be an important part of treatment. So as you can see, the management of chronic pain involves a lot of different tools and managing different modalities and different medications and different procedures. When we look at the neuroanatomy, opioids relieve pain by both raising the pain threshold at the spinal cord and also, more importantly, altering the brain perception of the pain. So it works in the spinal cord area, mostly in the dorsal horn, and also in the brain by affecting pain perception. So when we look at opioids, they can work on the ascending transmission of pain to the brain. They can work on the descending fibers from the brain down the spinal cord as an inhibitory system. They can inhibit the C terminals at the spinal cord, which are the pain fibers. They also can activate the nociceptors, inhibit the activation nociceptors at the peripheral nociceptor area. So you can see the slide and how opioids are an integral part of pain control, but also there are many other medications or tools that can be used in that area also. So when we look at closer at the spinal side and the dorsal horn, the opioids receptors will couple to the inhibitory G protein in high concentration in the dorsal horn, which leads to hyperpolarization, which causes inhibition of the pain signals to the brain going through the spinal cord. So when pain signals are initiated peripherally by the primary neuron and connect to the dorsal horn secondary neurons, this is where a lot of the pain modulation occurs. So opioid acting at the presynaptic opioid receptors stop the pain signals by closure of the calcium channels, leading to less release of excitatory neurotransmitters like substance P and glutamate from the primary neuron, and leads to decrease in action potential at the secondary neuron where they connect the nerve neurons, and hyperpolarization prevents nearby voltage gated sodium channels from opening and therefore causes opening of the potassium channels, which again leads to hyperpolarization and decrease in action potential frequency, causing less pain signals to be sent to the brain through the spinothalamic tract at the dorsal horn. So in simple terms, it's basically able to reduce the neurotransmitter release of substance P, the glutamine, by manipulating the calcium and potassium and sodium channels. So now we understand a little bit of the pathophysiology. Let's talk a little bit more about the opioid receptors. And there are really three main opioid receptors that are found in the brain, spinal cord, and peripheral nervous system. We'll talk a little bit more in depth. These three main receptors are the mu, kappa, and delta. And again, these three receptors actually are different in cellular distribution, how their binding power to the opioids and to various opioids, and contribution to how they affect pain control. So opioid receptors, again, we discussed this earlier, they couple to the inhibitory G protein in high concentration in the dorsal horn. And opioid relieve pain by both raising the pain threshold, as we spoke earlier, the spinal cord, and alter the brain perception of pain. We talked about how they increase the potassium efflux or hyperpolarization, or by opening this potassium channel, preventing opening of the calcium channels, and therefore stop the release of the substance P, glutamate, neurokinins, which are the excitatory neurotransmitters. So these three different types are the mu receptors, which are the ones commonly involved with analgesia or pain control, can cause euphoria, sedation, respiratory depression, dependence, pupil constriction, constipation. The delta are involved more in the analgesia at the spinal level, constipation, respiratory depression also, decrease in GI secretion. Kappa are involved more in dysphoria, to a lesser level analgesia at the spinal level. So when we look at the mu receptors, they can be located outside the spinal cord. They have very high affinity, and this is the mu receptor 1, affinity for morphine. We talked about these are the ones really involved more in pain control, supraspinal analgesia in the brain, selective blocked by naloxone. So when you give somebody naloxone, it blocks the mu receptors as an antagonist. Again, mu2 are located throughout the central nervous system, responsible also for spinal analgesia, but also the side effects of opioid like respiratory depression, constipation, physical dependence, and euphoria. Now, delta receptors have a higher affinity for endogenous ligands. The delta also mediate analgesia, mainly in the spinal area, and can be more of an effective component, which is the dysphoria and euphoria that can happen in the limbic system, and this is responsible for the dependence and reinforcement action. And this basically occurs through the dopamine receptors and also the pre-convulsant action is more prominent in the delta receptors. Now the third one and the kappa receptors again are involved in analgesia of the supraspinal area. They're not involved in respiratory depression much or dependence, but can be involved in dysphoria, meiosis, and reduced GI motility, which is common with constipation induced by opioids. Now, the interesting thing, there is significant genetic polymorphism when it comes to mu receptors. And this is why when a patient is introduced to an opioid, they're not going to respond the same as another patient. And also this is where incomplete cross tolerance among different opioids happens. So if you introduce one opioid and you want to wean them off that opioid and you want to start another one, that doesn't mean you can start them on equal analgesic dose, because the second opioid may attack different receptors depending how the patient you're giving it to responds because of their genetic makeup. So mu opioid receptors exhibit multiple polymorphism that can lead to increase in risk of drug abuse or protect against opioid side effects. So how many times we've seen a patient who can take Norco, a significant amount of Norco with no side effect, and somebody who takes even a small amount and has significant side effects. And again, that has to do with the genetic makeup and the polymorphism, and also how they respond to pain. Somebody may respond to pain very well to a small dose of hydrocodone, while somebody else may take a very high dose of hydrocodone and not respond with the pain control. So patient vary in response not only to the same medication, but different dosages. There's something like more than 3,000 polymorphism in human mu opioid receptor. So again, cross tolerance, how they absorb the medication, what side effects they will have. Those are all things to think about with different patients. So looking at an example of polymorphism, you can, although the mu opioid typically bind to all of the different receptors variants, their ability to activate them can vary. So if we have a hypothetical example of two drugs with different activation profiles of different mu receptors and subtypes, it can lead to incomplete cross tolerance among different mu receptors, ligands, which reflect the different selectivity of the mu gene receptors. And this is why one medication opioid cannot be just replaced by another opioid at the same equal analgesic dose, because of possibility of side effects and harm to the patient because of these different cross tolerance and gene receptors. So when you look at opioids, they differ in many different ways. Some of them are agonists, like a morphine or hydrocodone. They can act like a heroin, morphine, or a partial agonist like buprenorphine, like Butrans or Belbuca, or it can be a total antagonist like naloxone. So when we look at different medication, they also have different metabolic metabolism. For example, the CYP2D6 polymorphism affects opioids in a very significant way. So most commonly, if you prescribe an oral opioid like codeine or hydrocodone, these medications are the prodrugs. They have to be broken down and metabolized to be effective. Otherwise, they are inactive. So codeine, for example, has to be converted to morphine by a CYP2D6 enzyme. Therefore, it's the morphine, not the codeine, that results in patient's analgesia. So if the patient is deficient in this enzyme, no matter how much codeine is given to this patient, they will not receive any analgesic effect. The same is true of hydrocodone, which breaks down to hydromorphone, or Percocet or oxycodone breaking down to oxymorphone, its active component. Same thing with medication like Tramadol. They have to be broken down by a different enzyme, 2D6. And this is why some patients, even on higher doses of medication, do not receive any analgesia. So when we look at opioids, opioids are actually the synthetic form, the heroin, the opium. Now man has developed many semi-synthetic and synthetic drugs, and these can be classified into hydrocodone, like Vicodin or Norco, or hydromorphone like Dilaudid, and oxycodone or OxyContin or Percocet. Darvon or Darvocet has been taken off the market many years ago. But again, you can see the variability and knowing the pharmacology of these medication. And if we go to the next slide, it shows you that natural ones we talked about, morphine and codeine, but semi-synthetic could be the Percocet, oxymorphone, oxycodone, hydrocodone, hydromorphone. And then the synthetic ones are the fentanyl, the mepridine, which is Demerol, or the Methadone. So again, knowing their prodrug and their metabolites, and a lot of times the urine drug screens, especially the gas chromatography, is very nice because it shows you the patient is able to break down their prodrugs into their metabolites, and sometimes will give you some levels to help you understand if they're breaking down these drugs. Because as we discussed earlier, there are patients who cannot break these drugs down into their active metabolites, therefore not receiving any relief or analgesia. So again, the prototype of morphine, which originally was extracted from opium, and how morphine and codeine are connected. And then we talked a little bit about the synthetic drugs, which are man-made. So if we start looking into the specific drugs, we can classify them as short-acting, which are appropriate for treatment of acute pain, for breakthrough pain, incident pain, whereas the long-acting are better for continuous around-the-clock type of pain. They can both provide good analgesia. The shorter acting are quicker to act, but not as long lasting. The long acting are slower to act, but they will stay in the system longer. So again, it's important to understand your mechanism of action and what goal are you trying to accomplish with opioid management as a tool. And again, how's your patient responding to these different tools? Then if we look at possible mechanisms of tolerance, physical dependence, which can develop upon repeated doses of opioids, and potential of developing psychological dependence, physical dependence, tolerance, and all of these are neuroadaptation to the opioids due to their receptors from chronic exposure to an opioid. And these are very distinct and very separate. And it's very important to understand this. These are very distinct and separate than abuse or addiction. And multiple other medications that are given for other medical conditions, patient can develop tolerance and dependence. So patient, again, who are on prolonged therapy of opioids will develop the physical and psychological tolerance. And a big factor in this is when the patient is abruptly discontinued off the medication or treatment, they develop withdrawal signs. And there are two proposed mechanisms of tolerance. These are upregulation of CAMP system, downregulation of the mu receptors. And recent research suggests that tolerance results due to uncoupling between the mu receptors and G protein, which we discussed recently, and possibly reversal of the second messenger and ion channels, which we also discussed earlier. So tolerance, again, is developed at the receptor site, and tolerance can be not only developed to the receptor site, which leads to decrease in analgesia, so a patient who needs higher doses because they're not responding to pain control as they were initially on a lower dose, or side effects such as euphoria or respiratory depression that can disappear or decrease as the patient develops tolerance to the medication. So the nice thing is when patients are started on a smaller dose and slowly built up, they develop tolerance to the side effect of respiratory depression, cognitive side effects, euphoria, but not constipation. For some reason, constipation is something that the patients do not develop tolerance to. So therefore, constipation is something that needs to be monitored on reassessment and treated. And sometimes maybe convulsions. So we talked about cross tolerance occurs between drugs acting on the same receptor, but not drugs acting on different receptors. So that should be kept in mind. So we talked about a little bit earlier about mechanism, the NMDA antagonist and the nitric oxide synthesis inhibition have been found to block morphine tolerance and dependence in animals, and also how analgesic action of morphine can be disassociated from tolerance and dependence, which means patient may develop tolerance to and dependence to the medication, but their analgesia may continue to be at the same level and not develop tolerance to. Let's talk a little bit more about dependence. These are signs and symptoms of withdrawal by opioid cessation, rapid dose reduction, or exposure to opioid antagonists such as naloxone. And this can last a few days, the withdrawal, and also the psychological dependence can last a lot longer, for months or years, and is associated with craving for the drug. Now, psychological dependence is facilitated through the dopamine receptor and transmission in the mesolimbic and mesocortical pathways, which activate endogenous reward pathways in the brain. Just like any other addictive drugs or chemicals are associated with the dopamine receptors in the brain system and reward system, it's also important in initiating and maintaining drug seeking behavior. We have multiple studies that show misuse rate is anywhere from 21 to 29% in patients who are on opioids, which basically is using medication contrary to the prescribed method or use. Psychological dependence rarely occurs in patients being given opioids for pain management, but in studies shows that addiction rate is anywhere from 8 to 12%. These are the patients who are continuing to use opioids even with potential harm. Again, this is rare with patients who are really managed for chronic pain reasons. Now, let's talk a little bit about withdrawal. What is withdrawal? Withdrawal of a drug causes significant distress and can cause also drug-seeking behavior. Patient can have sweating, lacrimation, tearing of the eyes, dehydration, fear, anxiety, feeling very restless, tremor, colicky or abdominal discomfort, or high blood pressure, high heart rate, can also develop weight loss. This is why a week-long acting receptor agonist like methadone is used for withdrawal symptoms from opioids, because they are weaker on the mu receptors or pain receptors or agonists, and they also have a long half-life, and therefore they are slowly discarded from the body and not an abrupt clearance through the kidney or livers as we see with other drugs. So when do you decide to convert somebody from a short-acting to a long-acting? Well, what are the advantages of a short-acting? Short-acting are good for patients who experience intermittent pain, and it's fast-acting, good for acute pain, breakthrough pain. But the disadvantage if somebody needs repetitive dosing, especially somebody who's having to take more than 3 to 4 tablets a day, this is where maybe the advantages of a long-acting come in for that patient who's got that chronic 24/7 pain, who's not controlled by just a few short-acting as needed throughout the day. So it may be more appropriate for patients who need that stability of analgesia throughout the day to function. The disadvantage is it takes a little bit longer to work from the initial dose. It has a delayed response. Therefore, it's really important to educate the patient that the action of these drugs and analgesia is going to take a few days until the patient reaches that good pharmacokinetic level of analgesia. So educate them not to call you the next day and tell you it's not working. They should at least give it a trial for 2 weeks before discussing increase in dose or other options in medication management or opioids. Again, make sure you have somebody who's got moderate to severe pain. So what are some of the side effects and how do we manage them? Well, nausea, vomiting is very common and side effect of opioids. We can either treat the nausea with antiemetics, for example, like if it's a nausea that has to do with upset stomach, maybe Reglan. If it's somebody who's got vertigo causing nausea, could be like a scopolamine patch. And so I think managing the nausea is important. Or if this is not controlled with medication, or taking medication after they eat, maybe then switching to a different opioid is appropriate. Another side effect could be sedation. Again, starting a lower dose if possible will help mitigate that side effect. Or adding another analgesic that's not sedating, or if all else fails and they have good analgesia but they still have sedation, maybe adding a stimulant like Provigil or Novigil may be a possibility. But again, we got to make sure we manage the side effects of those medication. Another side effect that we talked about earlier, that people do not develop tolerance. Unlike nausea and vomiting, people do develop tolerance, which is nice. Sedation, same thing, they develop tolerance too. But constipation, patients do not develop tolerance. This is something that continues to happen throughout opioid management. So we got to pre-educate patients and maybe pre-prevent. So treating prophylactically with stool softeners, laxatives, osmotic laxatives, I think is very important. Also non-pharmacological measures, and optimizing fluid, fiber in their diet, exercise, and if all else fails, maybe trying opioid-induced constipation medications such as Movantik, Amitiza, Linzess, and some of these actually work on the opioid receptors in the GI, but not opioid receptors that manage control pain in the spinal cord or the brain. So again, side effects are also not limited to those, but patient can have itching, which again, you can use antihistamines or switching the opioid themselves if it becomes a significant problem. Endocrine dysfunction, reduced libido. Again, this in men can be with lowering the testosterone. Patient may require testosterone replacement and maybe seeing an endocrinologist, especially if their pain is well controlled and you've tried other opioids and they're on a chronic medication. But also, this can occur also patients who have other chronic medical conditions, such as bad diabetes or other chronic issues. So exercise can also be helpful. Appropriate diet can help. Another side effect could be edema or sweating. If it's significant, again, we have to switch the opioids to a different class. Dizziness, again, something that helps with the vertigo, as we discussed earlier, like scopolamine. Again, make sure also it's not some other factors that are causing the dizziness. And again, if it's significant, you may have to switch the opioid. And last, confusion. Usually, this is something you can avoid if you start with titrating the dose at a smaller dose and building up, or all else fails is switching the opioid to a different class. So now we're going to get into a little bit more specific drugs. We're going to start with Tramadol, which is a weak mu opioid. It's a weak inhibitory also not only of mu receptors, but serotonin and norepinephrine reuptake inhibition in the descending fibers. So it's a very atypical, unusual narcotic. Initially, it was not even listed as a controlled substance when it was approved by the FDA. Studies have shown that Tramadol is effective in peripheral neuropathy, postherpetic neuralgia, radiculopathy, phantom limb pain. Usually a starting dose of 50 milligrams once a day or twice a day as needed, can be gradually increased to 100 milligrams 4 times a day, which is the maximum dose. Common side effect, just like any other opioid, sedation, constipation, hypotension. And there's been some cases of lowering seizure threshold, especially at higher doses, more than 400 milligrams or close to that dose. When we look at Ultram, can be used in pain management at 50 milligrams up to 400 a day. There's also a form of Ultram that was well studied by reducing the Tramadol to 37.5 milligrams and adding acetaminophen or Tylenol 350 milligrams. Studies show that Actually, there was decrease in side effects. There was increase in duration. It went from 4 hours to 6 hours. Increase in pain control. And also better post-operative pain control. Therefore, if a patient is having some of these side effects, not getting good pain control, either consider adding a Tylenol 500 or extra strength to their dose instead of doubling it, or possibly prescribing Ultraset and see if they get less side effects and better pain control. So this is something to be kept in mind when patients are having either side effects or poor analgesia from Tramadol. So Tramadol comes also in an extended release form for those patients who are having around-the-clock pain. It's actually a simple once-a-day dose, 100, 200, 300 milligrams. Again, it works around the clock, has sustained efficacy throughout the day. Fewer peaks and valleys. That's the beauty of having a sustained release. It keeps you a little bit more even throughout the day for pain control. Can be used with a short-acting, but again, make sure you're not exceeding the 400 milligrams total per day. Again, that gradual rise in Cmax allows patient to adapt to it easier, but again, they're not going to get that quick effect like the short-acting. So they may tell you it's not working as well initially, but again, as long as they keep taking it after a few days, their pharmacokinetic makeup or mechanisms will give them better analgesia, and also does not have black box warning associated with NSAID, COX-2, or scheduled opioids. So when we look at the studies of efficacy of Tramadol, actually the studies show that Tramadol in a randomized double-blind placebo-controlled crossover trial evaluated the efficacy of Tramadol versus placebo. Patients who were started on a 200 milligrams a day or lesser dose and titrated, in patients who had painful polyneuropathy, overall, their response to pain, paresthesias, and allodynia was significant enough to patients who received placebo. So the research concluded that Tramadol relieves both continuing pain symptoms and allodynia in patients with painful polyneuropathy. Now, the next class of medication is codeine, which, as we discussed earlier, is a prodrug to morphine. It has 1/10 of a potency of morphine, so equal analgesically, it's about 1/10 or 10% of morphine. It can work also on diarrhea and nausea. Codeine is also a weak narcotic, mu opioid receptor, and again, can also relieve cough, in patients by using the codeine, and similar to morphine or hydrocodone, which also can help with cough. Again, as we discussed earlier, people can have a genetic variance, which can lead to slow or rapid conversion. Therefore, if a patient is not responding, you got to look into this possibility. It's combined with aspirin or Tylenol. It's a Scheduled 3 drug. And 90% of it is excreted through the kidney. So again, patients who have kidney issues, you may want to use a lower dose or maybe a different class of opioids. It's metabolized again by the CYP2D6 enzyme, as we discussed earlier. The next class is hydrocodone, which a lot of us know as Norco or previously Vicodin, semi-synthetic opioid mu agonist. The prodrug is hydrocodone and neurohydrocodone and hydromorphone. The hydrocodone is the inactive metabolite, but it's broken down into active metabolite, the hydromorphone, which is the one that helps with analgesia. It comes in many different short-acting forms. It's a Schedule 3. Now it used to be a Schedule 3, now it's a Schedule 2. We'll talk a little bit about a couple of long-acting hydrocodone, the Hydro and Hyslinga. We talked a little bit earlier about genetic variants. Approximately 7% of Caucasians and 3% of blacks and 1% of Asians are poor metabolizers, causing a slower rate of conversion of hydrocodone to hydromorphone. So if you have a patient who is taking a few hydrocodone a day and it still tells you it's not helping or it's not controlling the pain at all, maybe they are poor metabolizers or slow metabolizers. So you got to remember that because of the genetic variance in different patients. Half-life is about 4 to 6 hours, and maximum concentration usually within an hour. A long-acting form of hydrocodone is a hydro extended release, comes in 10, 15, 20, 30, 40, and 50 milligram doses. These are Q12 hours. There is no acetaminophen combined with this, therefore you're not concerned about hepatic impairment. Can be easily converted from hydrocodone 1-to-1. You can use short-acting with the long-acting, but the beauty of the hydro, it has a mix of instant release and the long-acting release. So the instant release can be effective within 30 minutes of the first dose. So it gives you that initial peak, and then the long-acting will give you that steady state for 12 hours. So it doesn't give you the peaks and troughs as much, as more steady. It comes in an abuse deterrent technology for those patients that are at risk for abuse or shown signs of abuse. Hyslinga was another extended release. Hydrocodone comes in also multiple doses, also Q12 hours. Again, no acetaminophen, easy conversion 1-to-1. This extended release does not have a form of instant release or with the extended release, so it takes a little bit longer for initial action. It does have abuse deterrent technology also. Initially, when it was brought to the market, it did not. Now we'll get into something also very familiar to the pain management world, is the morphine. Initially, in the 1800s, was isolated from raw opium. Drug of choice for analgesia because it's reliable, predictable effects, safety profile, and easily reversed with naloxone. It can achieve analgesia very quickly. Half-life is 2 to 3 hours, especially if it's given in the IV form. In the PO form, it can last longer. It's not very lipophilic, but still crosses the blood-brain barrier. Metabolized by conjugation of the glucuronide to its active form, the morphine 6 glucuronide, and this is the active form of the parent drug, the morphine. So again, it has to be broken down, and if a patient is not able to break it down, more likely will not have good analgesia from the morphine. The next drug we'll talk about is Hydromorphone, which also comes in the form of a brand name Dilaudid. This is 4 to 5 times more potent than morphine. So for example, if you're looking at the equal analgesic doses, a morphine 10 milligrams would be equal to about 2 to 2.5 milligrams of Dilaudid. Has very rapid onset, longer analgesia than fentanyl, excellent bioavailability. Again, the P450 system, which talked about the enzyme, this does not interfere with it, therefore it does not have to be broken down. This is the prodrug, the metabolite itself. Great for epidural infusion, rapid onset, and may have shorter duration of action than morphine. So in instant bioavailability, but again, may not last as long. Now, a long-acting form of hydromorphone is Exalgo. This, again, does not go through the P450 system. It's a once-a-day dose. It comes in 4 different doses. It can only be given to patients who are opioid tolerant. It gives you a good steady state of plasma as a long-acting. The next drug we'll talk about is something that's well known to the pain world and also the addiction world. We discussed earlier why it's good for addiction or withdrawal symptoms. Methadone itself has a long duration, and analgesia can last up to 24 hours. But unfortunately, it has toxic metabolites that can last up to 72 hours, even beyond the analgesia, which you can imagine if a patient is taking this pill on a regular basis, but the toxic metabolite are not excreted, they can build up in the system and cause significant side effects. These can be delirium, hyperalgesia, seizures, respiratory depression. Again, these not only are used for chronic pain, but in chronic pain, they have to be used every 12 hours initially, very small doses, titrating it to 3 to 4 times a day slowly. So again, this medication, you have to be very cautious not to use it as needed, but to only use it as prescribed twice a day initially, and titrate it at least every 3 to 4 days. And if these directions are not followed closely, the patient can have detrimental side effects. So initially, you may need another short acting until pain is better controlled with a methadone and the patient becomes more tolerant. It does come in different doses, anywhere from 2.5 milligrams to 10 milligrams orally. As we discussed, can be used for opioid withdrawal. Usually, the nice thing, it has less cognitive impairment and euphoria. And another nice thing, not only does it work on the mu opioid receptors, like other opioids, but methadone can also work on antagonizing the NMDA receptor, which also contribute to analgesia, decrease in adverse side effects, and inhibit tolerance. So it has multiple actions which allow it to work on different mechanisms to a smaller dose for pain control. It is a synthetic opioid, as we discussed earlier. Now, next we'll discuss another drug that's very potent, 80 to 100 times more potent than morphine. Very lipid soluble, therefore very quick acting, and because it is highly lipid soluble, it can be used in a buccal patch through the oral mucosa or a transdermal patch on the skin. Comes in multiple doses. It's a 72 hours effective. Can only be used in opioid tolerant patients. So if somebody's not opioid tolerant, this is not a medication that should be used on initial pain management. It does come in injectable form for anesthesia, not for pain management. Can be used for patients who have significant postoperative pain, but not in the world of chronic pain management as an IV. We have to be very careful that it can be absorbed at a higher level through the skin. If it's exposed to hot pack, or somebody has a fever, or is very warm from exercise. So these are kind of possible side effects that the patient has to be educated on. It's metabolized through the liver and the intestinal mucosa. Another drug where you have to start with smaller doses and build up because of its possible detrimental side effects. Now, the next drug we're going to talk about is a little different than the drugs or opioids we have been discussing, because it's a partial opioid agonist. So it's a class 3 scheduled opioid, proven in efficacy in chronic pain. So can be used every 12 hours for dosing. Very flexible doses, anywhere from 75 micrograms to 900 twice a day, versus the Butrans patch, which is not as flexible with the doses. Can be used in opioid naive patients, unlike fentanyl patch, or we talked about Exalgo or some of the other drugs. And it actually has lower risk of respiratory depression and also cognition and some of the other side effects we see, like euphoria. So something to consider in patients that maybe have a history of COPD or respiratory issues, or somebody you're concerned about because there are multiple medications. I think this is something to think about because it is a partial opioid agonist and it has a plateau or a ceiling effect on respiratory depression, even with higher doses. So how do we convert somebody from another opioid to Belbuca? Well, you have to start on calculating the morphine milliequivalent equal analgesic dose. So for example, if somebody's on Norco, 10 milligrams 3 times a day, that's every milligram of hydrocodone is equal to 1 milligram morphine. So that would be about 30 milligrams of morphine a day. So there, if you look at this table, you probably want to start with either 75 micrograms once a day or 12 hours, probably every 12 hours, and then wean them off the hydrocodone and use it only if needed for a breakthrough. And then gradually you can increase to 150, 300, 450. But again, I would not do this sooner than maybe every 2 weeks. Again, thinking about the pharmacokinetics of these medications and how they work. So this is something you have to educate the patient. But if you have somebody who's younger, who you feel more comfortable, who's not on other drugs or medication, you may want to start a little higher to give them a little better analgesia, maybe starting at 150. But if somebody who's frail, maybe starting with 75 is a good dose. Again, looking down at the table, if they're between 30 to 90, maybe starting them on 150, but more likely 300 microgram of Belbuca twice a day. Then if you get into the higher doses, this is where it becomes a little tricky, especially if patients are on more than 160 milliequivalent morphine, then probably either weaning them down off the morphine to a smaller dose and then introducing Belbuca, or considering other analgesic. So again, Belbuca can be a great asset for your patients who are on opioids that are not giving them the analgesia, or they're requiring multiple short acting. This is where I think Belbuca can be beneficial. A Butrans, which we'll talk about, is a transdermal patch. It's a 7-day patch. It's for moderate to severe chronic pain, not for acute pain. Opioid naive patient can start on 5 micrograms. Again, these may not reach that plateau until 3 days into wearing the patch. So again, educate the patient not to call you the next day and tell you it's not working. Can rotate from different sites, especially if they're developing itchiness or a reaction to the area over the skin. Again, they're available in different dosages, but not greater than 20 microgram. Again, this gives you a little bit titration table, similar to what we talked about. Again, the best way to do it, again, look at the morphine milliequivalency. Again, if they're on less than 30, probably a 5 microgram patch may work. If they're more than 30, probably 10. And then if they're on higher doses, maybe Butrans is not an appropriate opioid for them. The other concern with Belbuca and Butrans is also possible Q2C prolongation on their EKG. So again, if you got somebody on higher doses, and similar to Methadone, maybe performing an EKG to make sure you do not have any QTC interval prolongation causing any arrhythmias, something to keep an eye on. So now that we looked at different drugs, we talked a little bit about the pharmacology and the physiology. Let's go over the ground rules for prescribing opioid analgesia. Remember, patient selection is important, is very key. Assessment with history and exam is mandatory. Risk assessment is mandatory. A pain agreement is mandatory. Urine drug screens and Michigan Automated Prescription System report review every time you reassess a patient are mandatory. Remembering opioids are one tool of comprehensive treatment plan. So if that tool is not working, or if you have not already exhausted other tools, maybe opioid may not be appropriate for this patient. Again, opioid should be a trial first, and patients should be monitored closely. Patients should be reassessed every month or every 2 to 3 months, depending on their dosage of opioid and their risk, their medical conditions. Again, medical treatment can be continued if they're, meeting the 4A's, the analgesia, the improvement in function, activities, daily living. They're not having any adverse effect, and they're not showing any signs of addiction. If they are not meeting those 4A's, maybe modifying their treatment or discontinuing their treatment is appropriate. So we talked about the exit strategy. Despite the difficulties that we see in chronic pain syndrome, I think opioids still have a good role in therapeutic management in achieving relief of pain and more significant improving their quality of life and function, which is something we always have to reassess and document on a regular basis. So what did we learn from this that we can use in our practice? Medication are an adjunct to treatment. They are not the only tool. They are not a quick fix. They are not the sole treatment. So I think if you remember that and discuss that with the patient, I use the analogy that a carpenter cannot build a house with just a hammer. He needs multiple different tools to be able to build a house. And if he's only using a hammer, probably the product is not going to be very good. Choosing medication is based on mechanism of action. So learning the mechanism of action, the pharmacology of different opioids is crucial to doing a good job with opioid management. Keeping an eye on the patient, monitoring side effects, treating those side effects, prophylactically managing those side effects, and are an important part of opioid management. Always reviewing their need for medication or possibly reducing their medication. Polypharmacy can be acceptable in the world of chronic pain management, and juggling medication dosages may be needed. Despite the difficulties that we see in chronic pain syndromes, again, I think, as we discussed earlier, looking at patients' function, quality of life is very important to discuss with the patient. And even when they tell you their pain is 10 out of 10, you got to discuss with them and educate them how they're improving in their function, how their quality of life is improving. Because, again, those are not just numeric measurements. Those are more functional measurements, which can be important to manage a patient with chronic pain. And also, I think just as important is coordinating pain management with other providers for not only improving the patient's quality of life and function, maybe using a psychologist or a physical therapist to manage their pain using different modalities, which can lead in, or, exercises and yoga or Pilates or meditation can empower the patient for better outcome. Now, in summary, again, customizing therapy due to variance in response. We talked about how genetic makeup is variable and how people break down medications. So again, we gotta make sure we're keeping that in our knowledge of managing these different patients who are individuals, and looking also at the possible individual side effects of these medication, rationale for polypharmacy, looking at the mechanism, drug synergy, how one medication can be used as an additive effect, complementary to the medication. Therefore, using two medications with lesser dosages can prevent side effects in improvement in analgesia and pain control. And also, if all else fails, maybe consulting another subspecialist or specialist, patients who are not responding to your treatment plan. And never lose focus that you're managing the entire patient. So it's not only a physical management, it's a psychological management. So managing pain is emotional, in addition to being physical. So I hope this lecture opened your understanding and improved your knowledge on chronic pain management and the pharmacology, and keeping an open mind in managing those chronic pain patients. So I want to thank you for listening, and have a good day.